Now let's discuss inguinal hernias. This is very high yield information, so it's important that we know everything we can. First things first, we want to go over the layers of the abdomen, or the abdominal layers. Now, from superficial to deep, it's important that we know exactly what we're dealing with. So, from the most superficial aspect, we have the skin. Then we have fascia. Now, when it comes to fascia, we have two types. We have Camper's fascia, and the Camper's fascia is a fatty superficial layer. Under that, we have what is known as Scarpa's fascia. Scarpa's fascia is a deep and fibrous layer. Then we have muscle. The muscles are the rectus abdominis, the external oblique, the internal oblique, and the transverse abdominis. Deep to the muscle, we have transversalis fascia, and then below that we have the peritoneum. So that's just a look at the layers of the abdominal region from most superficial to deep. Now let's talk about the different types of inguinal hernias that we're going to see. The first thing we need to understand is the anatomy that make up the borders of the inguinal triangle. So if we consider that we have a triangle on both sides of the abdomen, just like this, what we're dealing with medially, this is your rectus abdominis. And what we have here is a larger image. So here is your rectus abdominis muscle, and the medial portion of your inguinal triangle is made up by the lateral margin of the rectus sheath. So the medial border is made up of the lateral margin of the rectus sheath. Now we have a lateral but superior border and a lateral but inferior border. Now our inferior lateral border is made up right here, and this is the inguinal ligament. Okay, and that's going to be your inferolateral portion of the inguinal triangle, or the inferolateral border. Now the superior-lateral, this is made up by your inferior epigastric vessels. Okay, so medially, we're dealing with the lateral margin of the rectus sheath. Superolaterally, we're dealing with the inferior epigastric vessels. And then inferolaterally, we're dealing with our inguinal ligament. So now we need to understand exactly what type of inguinal hernias occur and where. So now let's discuss the types of hernias that we see in the inguinal region. These are known as inguinal hernias, and these are the most common type of hernias. We see them more often in men than women. Now in women, we'll see what are known as femoral hernias, which we'll discuss shortly. Now usually when you see these, surgical correction is going to be what we're going to need to do. So let's discuss the different types. We have a direct inguinal hernia and an indirect inguinal hernia. The direct inguinal hernia is going to protrude directly through the abdominal wall medial to your inferior epigastric artery, meaning over here. So medial to your inferior epigastric artery. And when it protrudes, it's going to protrude through the superficial inguinal ring. Now the indirect hernia is going to protrude laterally to the inferior epigastric artery, and it's actually going to go into the spermatic cord. And in doing so, it travels through the deep and the superficial inguinal rings into the scrotum. Now, the reason why you see an indirect inguinal hernia is because we have a failure of closure of something. And what we see is failure of closure of something known as the processus vaginalis. Now, one of the tools we can use to identify whether or not what we're palpating in the scrotum is a varicocele, a hydrocele, or an indirect inguinal hernia, which will be GI tissue, is to simply listen to it. If we put the stethoscope on the scrotal sac where we feel the bulge and we hear little tinkling sounds, that's the GI working. Okay, so it's a very easy way by which we can identify whether or not we have GI structures within the scrotum. Now let's discuss femoral hernias. As we said, femoral hernias are seen more often in females than they will be in males, whereas the inguinal hernias, it's the other way around. So obviously, whenever we're talking about these hernias, we want to know the anatomy. Now, if we're looking at a drawing here of the right leg, that means the medial aspect is here and the lateral aspect is here. Now, what are the borders that make up the femoral triangle? Now, this imaginary triangle is going to be right here. So if we look at the borders superiorly, what we're looking at right here is the inguinal ligament. So the superior border is made up by the inguinal ligament. Laterally, this is the sartorius muscle, a very long muscle. Okay, that's going to make up our lateral border. And then medially, what we have here is our adductor longus muscle right in here, this big muscle here. So that's our medial border. And these three structures make up what is known as the femoral triangle. Now, if we want to talk about the hernia, it protrudes in this region here. Now, we have the pubic tubercle right around here, and the femoral hernia will protrude through the femoral triangle below and lateral to that pubic tubercle. So right in this region here. Now, what are some of the contents found within our femoral triangle? Well, we have the femoral artery as well as its branches. We have the femoral vein. We have the femoral nerve. And the femoral nerve, keep in mind, is outside of the femoral sheath. We have the lateral cutaneous nerve. We have the femoral branches of the genitofemoral nerve. And we have lymph vessels. And we also have the inguinal lymph nodes. Okay, so those are some of the most important contents within our femoral triangle. Now, because of the location of the typical femoral hernia right below this inguinal ligament, we have a very high risk of incarceration. Remember, ligaments are tough fibrous structures, so if something bulges below that, it risks the chance that the blood supply is going to be either slowed or completely stopped. And if that's the case, we risk that that tissue is going to die, and we have to urgently bring our patient to surgery. So we said we risk cutting off the blood supply, which would mean strangulation. But we have different categories of the degree of hernia. So let's go over those. There's essentially three. There's a reducible hernia, an incarcerated hernia, and a strangulated hernia. Let's talk about each one of those now. A reducible hernia, this means that the tissue that herniates can be put back into its normal anatomical location. So we can take it with our finger and push it back, and it'll stay there. And obviously, this is the least severe of all types. An incarcerated hernia means the herniated tissue is not reducible manually. Now, when this tissue keeps popping out and it won't stay where it needs to be, we have an increased risk of strangulation. And finally, a strangulated hernia. This means the vascular supply has been compromised. Now, as a result, patients have a high risk of ischemia. And when that happens, that means the tissue is at risk of dying. And if that happens, then it's even more of a complex issue. So our goal is to get them to surgery and help to restore the vascular supply so that tissue can avoid ischemia and we keep it nice and alive.